everybody. It's a great pleasure today to welcome you on behalf of Hourglass to this webinar on the last taboo, sexual abuse in older adults. I would like to start by thanking you for giving your time to come for this educational session today. I know time is the most precious commodity that we all have. Just a couple of housekeeping things that I want to say. This webinar is being recorded, so the speakers will be recorded and that will be available for you to listen to again or to suggest your colleagues might listen to it. And that will be in a day or two's time when it's been tidied up and edited by those wizards in the background that I can't hope to emulate. I'd like to thank the organisers for doing all that. I'd like to thank all our speakers in advance, and they're going to introduce themselves in a moment. But most of all, again, I wish to thank you for your interest in this topic, your interest in Hourglass, and the time that you've given up today. Now, I appreciate that this is the last taboo. This is a very difficult subject. And I want to talk about self-care before we go on to any content. This is about gaining knowledge, ability, and empowerment to deal with this difficult subject. And if we do not look after ourselves, we don't have those things. We are not empowered to look after the vulnerable people that we are dedicated to. So please, if this difficult subject is more than you're up to today, please pause. Look after yourself. You can come back to the recording, perhaps when somebody else is around to support you, or things that make this a difficult day have faded into the background. So please do look after yourselves and don't feel that you've got to stick with this. You can come back to it to complete your learning if it's too difficult. Okay, now we've got a timetable to stick to, so I've probably said more than that I allocated myself time to say. I'll repeat some of the housekeeping messages at the end. So I'll explain a bit more about the feedback that's going to be available to you. I'm also going to plug shamelessly the Hourglass conference when we get to the end. And I'm going to ask you to continue to support Hourglass. So now I'm going to pass over to everybody else to do the self-introduction, but I hope perhaps to say just a word about my background. I'm a mostly retired consultant geriatrician. I do medical legal work now rather than clinical work. I haven't worked in the NHS for a couple of years. My interest in this topic was triggered by experiences as a trainee when, frankly, I did not get any training. I worked in an area that included Soho, which at that time was a centre of sex workers. And there were some older women involved. And my naivety, my ignorance, and everybody else's naivety, ignorance, and probably embarrassment meant that we did absolutely nothing. Roll forward to 10 years ago, and me giving a presentation to my trainees when I worked in Manchester. And I asked my colleagues what they knew about gerontophilia, and one of the consultants, more experienced than I was, said he had never heard the word, and he did not know anything about it. So I'm not sure we made a lot of progress. So it's one of my motivations for being here today. Now that's enough about me. I'm going to ask people to introduce themselves kind of in reverse order, with Amanda coming last. So Poppy, do you want to start?
Hi, so my name is Poppy. I work for Hourglass as a community response team leader, an independent domestic violence advisor and independent sexual violence advisor. Previously, I've worked in the health and social care sector, specialising previously in dementia care and end-of-life care.
Great, thank you, Poppy. Kate, would you introduce yourself next?
Hi everyone, thank you so much for having me here today. My name is Kate Worthington and I'm a senior practitioner at the Revenge Porn Helpline. We support all adults affected by intimate image abuse, which includes sharing of images without consent, threatening to share intimate images and taking images without consent. So I'm really pleased that the online world has been brought into these conversations, and I very much look forward to learning lots today, as well as contributing. So thank you.
Great. Maria, would you speak next?
I can, yes. Good morning, everyone. My name is Maria Putz. I'm the interim head of training at Limeculture. For those of you that haven't heard of Limeculture, that's absolutely fine. But we're a community interest company that specialises in sexual violence and safeguarding. And we provide training, development work and consultancy across a range of services such as frontline professionals, as Poppy, ISVA and IDVA, as well as universities, schools and police around their response to sexual violence and improving that response for frontline professionals to make sure anybody impacted by sexual violence gets the appropriate response, help and support and access to that as well.
Great, thank you very much. And I'm asking Amanda to introduce herself last and then go straight into her presentation. Amanda, would you introduce yourself?
Thank you, Mary. So I'm Amanda Warburton-Wynn. I'm an independent researcher and consultant, and I specialise in domestic abuse and sexual violence issues that affect older people and people with disabilities. And I also have a day job where I work for Cambridgeshire County Council. I'm part of the Domestic Abuse Partnership, where I lead on issues around older people and people with disabilities. So I'm just going to share my screen. Can someone just give me a shout to say that that's come up on the screen?
Yeah.
Yes, thank you. That has. I was trying to do it by the gestures, but I'm doing it in person here.
Thank you. So it's just that once I'm sharing the screen, you can't see the participants on the call, which is actually really good, because I think if I was doing this in real life, I would be even more nervous than I am. So I'm going to be talking about sexual assault and sexual violence against older people, and the issue really of, does anybody care? I'm just going to quickly echo the trigger warning that Mary gave at the beginning, just to say that some of what I'm talking about is quite upsetting. So just sort of remember to take care of yourselves. So I'm going to first of all talk about some research that Hourglass kindly published for me, and then I'm going to move on to a bit of a more general presentation. So I'm going to start with some pictures, and I don't know if anybody recognises the three women in these photographs. So the piece of research that I did first came up on my radar when the lady in the largest picture, Sarah Everard, when her horrific murder was all over the media and all over social media. And that had generated some hashtags. Mainly she was just walking home. And then shortly after that, we had again, horrific murders of Aisling Murphy and Sabina Nessa. And again, more hashtags were generated. There was a lot more discussion on social media, hashtags around she was just going for a run, etc. And whilst I was looking at all these, I saw just one reference to a story on Twitter, now called X, that mentioned this lady. So this lady was Mrs. Valerie Neal. She had died in 2018, and I really noticed that that was the first time I'd heard about what happened to Mrs. Neal, even though I have a strong interest in this area of work. And even when I started trying to get some interest in the case through social media, there were no hashtags for Mrs. Neal. And one I have suggested was hashtag she was in hospital recovering from a stroke. So Mrs. Neal was 75 and she was admitted to Blackpool Hospital in 2018 following a stroke. While she was in hospital, she had a fall, and shortly afterwards she passed away. Because of having the fall in hospital, there was a need to do a post-mortem. And unfortunately, the post-mortem established that her cause of death was not related to the stroke or the fall. It was actually hemorrhaging from an internal injury caused by sexual assault. And Blackpool Hospital have since sort of stated that that assault took place while she was in hospital. Initially, a member of the hospital staff was arrested, but there wasn't a charge made. But that person has since been sentenced to imprisonment for 8 sexual assaults on colleagues, but there wasn't enough evidence to charge him with the murder of Mrs. Neal. So the case is still open. In March last year, it featured on Crime Stoppers. The members of Mrs. Neal's family were on there, and Lancashire Police and Crime Stoppers have offered a reward of £20,000 for information about what happened to Mrs. Neal, and they're particularly appealing to staff that were working on that stroke unit at that time. And the inquest into Mrs. Neal's death has been postponed several times. It was last due at the beginning of December, where it was postponed again until May 2024. So we're going to be 6 years since her death, if the inquest does finally happen in May. And I just wanted to add that this particular stroke unit at Blackpool Hospital was the same stroke ward where 2 nurses were sentenced to 7 years and 3 years of imprisonment for giving sedatives to patients on the stroke ward to keep them quiet and compliant. And that was sort of towards the end of last year that those sentences were given. So perhaps it's not surprising that nobody from the ward is coming forward to explain what happened to Mrs. Neal. So when I put out a post on social media about this horrible case, I started getting a few messages back to say, well, this isn't the only case, that this is actually happening fairly regularly. So that led me to think about doing a little bit of research around it. So what I did was sent out the freedom of information requests to all the NHS trusts in England, asking about reports of sexual assault on patients aged 60 and over, where the alleged perpetrator was a member of hospital staff, and that included agency staff, and asked them to cover the previous 5 years. And I asked for, in particular, the number of reported incidents, the sex of the victim and the alleged perpetrator, the role of the perpetrator, whether the incident had been reported to the police, and the outcome of the police investigation, if there was one, and also whether any internal HR action was taken by the hospital. So the findings from that piece of research, I had 46 trusts that responded to say that they did hold data, and of those, 56 individual incidents were reported. 19 hospitals told me that they were unable to disclose exact numbers under the GDPR regulations, which some of them said that was because the number was less than 10, some said because it was less than 5. But so that meant when I did my counting up, I could only count at least 1 for all of those. But obviously where somebody said, well, it was less than 10, actually that could have been 9, we don't know. So that led to a total of at least 75 incidents had been reported over the last 5 years up to 2021. So when I break the data down that I was given, around 70% of the victims were female and around 70% of the alleged perpetrators were male. The role of the alleged perpetrator varied quite significantly from healthcare assistant through to surgeons and anaesthetists. 16 of those 75 incidents were reported to the police, and 14 of those were NFA'd by the police, no further action. And of the other incidents, the hospitals didn't know if they had been reported to the police or not, and they didn't know the outcome if they had been reported. And in terms of internal disciplinary action, 2 staff had been dismissed and 2 had been subjected to an internal disciplinary process. So as well as the sort of tick boxes that I got back on the returns, I also had a few sort of free text responses, and they were things like, well, the patient had dementia, so we weren't sure if they were telling the truth or not. The medication affected the patient's memory. The patient couldn't identify the perpetrator, so no action taken. Those kind of messages are obviously really quite worrying, but also thinking about these are people who are in hospital. In some cases, they would have been on medication. They may have had issues like dementia. They may have also been recovering from surgery, so under sort of anaesthesia. So it's not really surprising that they couldn't recall the exact details and the exact perpetrator. But because that they couldn't give these details, or because they had a dementia type illness, it was assumed that the assault didn't happen. So in terms of sharing the outcomes of my research, Hourglass very kindly published my report on their website, and I've presented it to the East of England Safeguarding Adults Board. I've also presented to the Birmingham City University, to students who are doing the Masters in Safeguarding. And I'm also working with Cambridgeshire and Peterborough Safeguarding Adults Board, and we've conducted an audit of the local NHS providers to ascertain what their procedures are if such incidents are reported. And the Safeguarding Adults Board have now asked us to move on to looking at the same questions around sexual assaults in care homes as well. So we're working on that next. So when I first put the research out there, to start with, there wasn't very much response, but slowly response started picking up. Last year, which was sort of just over a year since I first published it, I was contacted by the BBC, who said that they were doing a programme for the File on 4 programme on BBC Radio 4, and they wanted to talk about sexual assaults in the NHS. So I did quite a lengthy interview with them, and I had all the details through to say it was going to be going out on air and when it was going out, and I had started to spread the message about that because I was very keen to get the word out that this issue was actually going to get some media attention. And within about an hour before the programme went out, I got an email to say that they had just changed their mind really and decided that instead the programme was going to focus on NHS staff as victims of sexual assault from patients, which was quite disappointing. But then I was also contacted by 2 national newspapers around the same time, again, had interviews, quite extensive conversations with them. And again, it was decided at the last minute that they were going to actually run with stories about female hospital staff being assaulted by senior management and senior male staff. So that was very disappointing. It made me think, well, what's going on here? It's more than just a story. This is happening to people. This has led to at least one lady being murdered. Why aren't the press and the media interested in this? So I started sort of looking at some of the issues that could be behind that. So first of all, the real rape myth, which was introduced quite a few years ago now. And it's basically the stereotype of a real rape victim is a white young woman who's attacked at night by a stranger, and the motivation there is sexual gratification. And more recently, Dr. Hannah Bowes, who works from Durham University, has done some research around older victims of abuse. And in her paper, she said that victims who experience rape that doesn't fit into that real rape mould are often disbelieved or discredited. And that can then make them reluctant to report that rape to the police or other agencies. And that obviously linked in with some of the comments I got from my research around, well, they had dementia or they couldn't identify the perpetrator. Also, in terms of gathering data, the crime survey for England and Wales has been capped at age 59 until the last couple of years. So that has meant that there hasn't even been a way for this sort of the frequency that this is happening to be captured. So in terms of more information about the prevalence, the latest data from the Office of National Statistics estimates that around 798,000 women, 275,000 men, aged 16 and over, experienced sexual assault in the last year. That's from the Crime Survey for England and Wales, which doesn't cover care settings. It only covers private households. And they estimated that 1.5% of these were aged 60 to 74, but there was no breakdown for any other age groups. So they couldn't sort of give the data for people aged 75 plus. A report from the Care Quality Commission reported that between the 1st of March and 31st of May 2018, there were almost 900 sexual assault incidents or alleged incidents that took place in residential nursing homes that were reported to them. And again, going back to Dr. Hannah Bowes, her research has found that rape and sexual assault offences relating to older people, this is going back a few years, between 2009 and 2013, made up 0.75% of all cases. So the data that's out there is quite limited, and actually the data that there is isn't that robust. In terms of who the offenders are, this information goes back to a US study. Again, it was quite a few years ago, 2006. They looked at 284 cases. And they found of those that the majority were male offenders, although there were a small minority of female offenders. The offenders ranged in age from 13 up to 90. The largest age group of offenders was the 30 to 39 age group. And the next one was the 40 to 49 age group. So basically it's between that sort of 30 to 49 age group of offenders that are committing the sexual assaults on older people. In the 70 and older age group of perpetrators, there were 20 offenders that were aged in their 70s, and there were also smaller numbers that were sort of aged up into the 90s. So I wanted to talk a little bit about this case. It was known as the Night Stalker Operation Minstead. It's the case of a man called Delroy Grant, who was committing some very serious offences against older people. He had a sort of MO of particularly targeting older people. He would remove the light bulb or make some kind of sort of cutting to the electricity. He would commit a sexual assault on the older person first, and then afterwards he would burgle them. And very often the victims reported that he would apologise after he had done it. So the case got quite a lot of media attention. He was eventually convicted of 29 offences, which included 5 rapes, 6 indecent assaults and 11 burglaries, which I think is quite interesting in itself, because it was known that the rape and sexual assault was a feature of pretty much all of his offences, but he was charged for sort of a lot of burglary offences rather than sort of those offences really. So his victims ranged from the age of 68 to 93. Not all of them did disclose sexual assault, and 10 of his victims were men. And police believe that he could have attacked as many as 1,000 elderly women, was what they put in their statement, but he was also attacking men as well. So some of the media reports that are around this particular offender say things like, the police believe he has a sexual obsession with older people, so a gerontophile, which very much put the emphasis on him having a sexual fetish for older people, rather than thinking about the power and control element that is the motivator for the majority of sexual offences. Media reports also talked quite a lot about the elderly women that he had attacked, and no mention of the male victims. The phrase old age pensioners was used quite a lot as well, which is quite a not very nice phrase to use really. And in most cases, most media reports, the burglaries were actually mentioned higher up in the article, including in the headline and in the first few paragraphs, before the sexual attacks were actually mentioned as well. And that does fit in with the research of Dr. Bowes around these sexual crimes being viewed as less important when it comes to older victims. So this is a very recent piece of research, which came out from Australia. It was literally published about 2 weeks ago. So this was a thematic review on just over 2,000 social media comments that had been made in response to posts about sexual assault in what they call residential aged care facilities, so residential homes, nursing homes. So from analysing the comments that the public had made on these media reports, they found that most comments put the blame for these assaults on either the government and policies and funding and things like that, or the families of the victims. And that was things like, well, they shouldn't have put them in a home, it's their fault for not keeping them at home with them, those kind of comments. When they looked at comments where staff in that field, in that residential care field, had put across their opinions, it was mostly that disbelief that could happen within residential homes, and also minimising the impact, that both the frequency of it and the impact on the older people. And that included comments like, well, if the victim had dementia, they probably didn't really notice what was happening anyway, those kind of things. And they also found that in most cases there was a lack of physical evidence, which meant that these cases didn't go forward to a criminal investigation, which, looking at the public perception of that fact, didn't really generate any sort of outrage that these hadn't gone on to a criminal investigation. So I just want to finish off with a bit of information about what we can do. I mean, obviously everyone's here today because you've got a really strong interest in this topic. I think, as I've already alluded to, having more data and more robust data is important. Whilst on one hand, these type of cases, it should be much more about the individual and their experiences and the trauma they've experienced. Unfortunately, as we all know, funding for services relies on there being the data to show that there is a need for the service. So it is really important for more researchers to look into this area of work. The media could do quite a lot by giving more attention to these sort of cases, but without the unhelpful assumptions and the unhelpful language such as old age pensioners. They can also recognise that power and control is often the main motivator for sexual attacks across the board, rather than a particular fetish such as gerontophilia, although that can be an issue in some cases. There could also be some specific training around for professionals, around domestic abuse and sexual violence. Often these types of awareness are subsumed into safeguarding training, and they sort of put very little emphasis on the abuse and sexual violence in particular. So it would be useful to see some more quite specific training around this. Also, in terms of people who are professionals who are there when an incident is reported, very often these cases fail because there is no physical evidence. One of the outcomes I found from my research in hospitals was that it was very rare for the hospital to actually get in contact with the local sexual assault referral centre, who could actually do the forensics and sort of get evidence and things like that. And most of them weren't aware that the SARCs do actually have the ability to come out to the site of the incident if that person is unable to get to the SARC. So, sort of if the person is in hospital or in a residential care home, they can actually come out and do the forensics on the site. And also to report those issues to the police, even if it's you think, oh well, that nothing's going to happen anyway, it should still be reported. And then finally, don't assume or minimize the impact of the trauma on the victims, and things like, as I've already said, thinking, well, they've got dementia, they didn't really know what happened. Actually, we don't know the impact, and that can be very different for each individual. And there is specialist support out there from services like Red Crisis and places like that. So it's really important to always consider, even if you're not going forward or if you're not reporting to the police, to still offer that specialist support service referral as well. And then on my papers, which will be going out, there's just a link to some of the research papers that I've mentioned there. So thank you for listening.
Amanda, thank you very much. Super presentation. Thank you. Thank you, really, thank you. I'm going to start off the question session here while we get ourselves organised for any other questions that we may have ready. But I just want to say to the attendees that there'll be a combined question and answer session at the end of each presentation, so that the opportunity to ask questions of the whole panel and to pull together themes that might come out of each presentation will be there. But if I could ask, do you know anything about what I believe are called gateway offences or gateway behaviour? You've talked about really, really serious offences. I would say, from my experience, that there are displays of attitudes that are evident much, much earlier than the actual physical assaults that I have witnessed. And I just wonder if there is any evidence of gateway offences, gateway behaviour.
It's not something that I have come across, but I think it is, as I said, there is much more research needed in this area, and I think that would be a very interesting area of research, actually, because yeah, I have looked at serious sexual offences here, which is the the sort of worst end of the spectrum. But I'm sure older people are targeted for a lot of offences that we think of as less serious, I guess.
Yeah. Could you just say something then about what the definitions were for the offences? What definitions did those reporting to the CQC actually use?
So the CQC reporting was just any incident of any sexual assault or sexual abuse that had taken place within the care home. So that literally could cover from what sort of in police terms is sexual offences to serious sexual offences.
Maria, you have views on this.
Yeah, it's just with regards to the the escalating of behaviour, and we've done a lot of work around this, not specifically with older people, with a lot of schools and colleges, with regards to a society at the moment, we're normalising a lot of sexualised behaviour, which is inappropriate and sometimes illegal behaviour. Whether that can be catcalling, stalking, sexting, sextortion, bringing in the digital side as well as the real world, as people call it. And I think as a society, because we have normalised some behaviour, there's a normal escalation in what now is lower level behaviour. And actually what we've normalised is lower level behaviour. And this leaks into and feeds into some offender theories with regards to Finkelhall's model, where if I find someone that agrees with me, this is okay. And then I'll take the next step with regards to offender theories, etc. So there's lots of theories at the moment, like Amanda said, not a lot of research in this area, but a lot of discussions and theories with regards to, as society, we've normalised some sexualised, inappropriate, illegal behaviour, and actually that's allowed for behaviour to escalate, where we only see what would be deemed higher level incidents as the biggest issues, when actually we're not addressing and calling out inappropriate lower level behaviour. It's just completely normalised, whether it's locker room banter, corridor culture, normal workplace environments, things like that. And it's I think it's just having these discussions and getting society to start to question each other, so then people feel empowered to call out the lower level behaviours, because things are escalating, because as society we're accepting lower level behaviours as well. I've seen lots of triangles with regards to what's accepted and then how it can escalate, and rape and sexual violence being sort of the top of that triangle. And Amanda mentioned earlier the Sarah Everard case, and that was a perfect example with regards to that. The offender in that case was known to use inappropriate language, stalking behaviour, WhatsApp conversations, and then there was the groping and the flashing, and then we're aware of the rape and murder. So it shows how behaviour, if it's not questioned, can escalate as well. So there is lots of theories, but like Amanda said, not so much research, but there's lots of conversations at the moment about educating society so we don't start accepting higher levels as normalised behaviour.
Thank you. Yeah, I'd like to add into that I think there is generational respect issue here. And if an older person brought up with a particular moral framework, a particular set of values, says that this is offensive to them, then it is offensive, it is abusive. And it's not what a 20-year-old may think of as what you've referred to as normalization, that you share images on your phone. If you wouldn't share it with your own grandmother, or if your own grandmother, great-grandmother would say, that's inappropriate, words to that effect, then that's the definition of the harm. She finds it, he finds it offensive, it is offensive. Okay, thank you. I'm going to take a lot of the questions that have come in the chat and bring them up in the next in the big session, because there's so much, and we've got other things to bring in now. So could I ask Kate? Kate, are you okay to go next?
Yes, more than happy to. Yep, so I've got 10 minutes. I'll try and keep an eye on my clock to not run over too much. So Amanda, that presentation was so fascinating. Thank you so much. That research that you have sort of collated all together, including your own, was such a good overview. So thank you so much for that. Even I myself have learned a lot from you already. So I'm here today from the Revenge Porn Helpline, and I'm kind of hoping to contribute something towards more the digital side of how we see forms of abuse. So even the term revenge porn, the name of our helpline, doesn't help with this situation. We are trying to move away from the terminology revenge porn, firstly because it's not revenge and it's not porn. Revenge implies the person has done something wrong or done something to deserve what has happened to them, which is obviously not the case. And pornography should be something consensually produced for entertainment purposes, which this content is not. And the second kind of issue with this term revenge porn is also the way the media has sensationalized it to be a young person's issue. When we think about sort of stereotypical cases we see in the media of revenge porn, we think of young adults, breakdown of relationship, the boyfriend has gone on to share those images to cause distress to that partner, to humiliate them and lead them into further distress. Obviously that case does happen, but it really does sort of stereotype the type of behaviours and the type of people affected and the perpetrators that are involved in this type of abuse. So the forms of intimate image abuse that we do see, as I mentioned earlier, include the sharing of intimate images without consent, the threats to share, and the taking of intimate images. And this is a form of abuse. That is why we try to sort of use this term intimate image abuse. And as of the January the 31st, it will be included within the Sexual Offences Act. The Online Safety Act has brought in a change to the current legislation, and that has been enacted on the 31st of January. Don't know how publicly available they've made that yet, but hopefully that is true. We've heard from the Home Office. I'm hoping I'm not lying to you all today. And that is just for England and Wales. Obviously, Scotland and Northern Ireland and Ireland have their own legislation. But intimate image abuse really does affect all adults. The Revenge Porn Helpline is an 18+ helpline. When we talk about this issue with children, those under the age of 18, it is child sexual abuse material that is produced. So that is a separate issue. We are solely here to support adults. And there really isn't any discrimination with who is affected by this. I think there is a lot of media, as Amanda was sort of saying, and I was really furiously nodding my head towards, that the media really does like to pick up on these stories of young people affected. And it's almost sort of sensationalizing, sexualizing it in some ways. But on the helpline, we do receive cases from all walks of life. And that may be people who are older now, and it's a historic case going back 10, 20 years of their images from when they were younger have now been discovered online or shared. And there is quite a common trend at the moment, an online scam called sextortion, which I'm not sure how many people have heard about, but this is a scam that is affecting mainly men. Women as well, not exclusively men, but definitely more so. And older men are definitely being affected by this from the cases that we're seeing through to the helpline, but also our colleagues at the NCA are also finding this as well. Sextortion happens when a online sort of criminal gang targets somebody using a social media account, dating profile, creates a fake profile with a stereotypical, very attractive profile picture, befriends them, starts a quick relationship via sort of messenger communication, sort of invites them to either share intimate content or invites them to a webcam where intimate content is shared over video cam that is obtained and used to blackmail them for large amounts of money. And that can obviously lead to huge life-changing situations of financial loss, relationship loss, and mental health impacts as well. So that is definitely something that we're seeing affecting people. We do have limited demographic data available on the helpline for various reasons, but we do know that this type of abuse does affect everybody. I do think there are improvements that definitely could be made as well to the support that's provided. As I've said previously, that the media definitely picks up on this idea of it's a young person issue, it's even a child's issue, but it's really not. It can affect everybody. And a lot of the awareness that has been created is targeted at young people. The Home Office Enough campaign, I've been sitting in some of the meetings for that, and they really are sort of targeting young people with that campaign. And I was sitting there sort of arguing, what about the rural people? What about people who aren't seeing billboards, aren't sort of seeing social media ads for this? Obviously they have to use a demographic to target, but they really are leaving out a large proportion of the population within that awareness campaign that they're creating about bystander interventions, as Maria was saying, and other kind of forms of awareness of different forms of abuse. And I think going back to the policy brief that was published by Hourglass and Amanda's research as well, there is a lot of remaining ignorance in our views around the sort of stereotypes of what we think older people are. And it may be that we think they're not sexually active, they're not dating, they're not looking for future partners, they may not be sharing images consensually in their relationships. And actually, from having that ignorant view of them not being involved in that, we sort of miss out actually considering them as a group of people affected by this type of abuse. When we think of image sharing, we always think young people, but it's not to say that older people don't partake in that behaviour as well, which is completely fine, and everyone is entitled to healthy relationships. But equally, when those healthy relationships turn toxic and abuse happens, we also need to be there to provide them with support. And equally, professional services need to know that there are services in place to support them, signpost to ourselves and other services as well to be able to support them. I feel like I rattled through that quite quickly and I'm over. So I don't know, I can see the questions going off, so I don't know if there's any questions on the back of that or you're waiting for later, Mary, but thank you for listening.
Thank you very much indeed. Do you have any suggestions on getting this more appropriately into the domain that we're particularly interested in? This is not to say that it should not be in the domain that you have referred to. Of course, it's very important that it's specifically targeted to each age group that can be affected. But what would your suggestions be for the age group that Hourglass is particularly trying to assist? You know, not everybody has got the IT skills to do this, and not everybody wants to ask their grandchildren to assist them where they might be perfectly happy to ask them to fix the Netflix subscription.
Yes, no, and that's very true. I think it always comes back to research. I think that there is limited research in this area already, and a big needs assessment needs to be undertaken to actually understand the experiences of older people with intimate image abuse and different forms of online harm, to really understand the sort of the complexity of the issues that are being experienced, how they may differ to younger people, or the experiences that we hear on the helpline as well, to really understand the need, the demand, what is actually happening for us to respond. Obviously, once we've kind of done that research and really understood the issues, I think professionals training is always really important, getting in there with who they may be going to, GPs, nursing, even sort of hairdressers and things like that. There are so many parts of the workforce that can be so helpful in actually, there's been a lot of work done with domestic abuse and hairdressing, and I just think that's absolutely fantastic. My own hairdresser has had that training and we chat about it all the time, and it's really important to sort of involve the whole types of workforce and who we may interact with, and ensuring that everyone is sort of involved in this conversation. And I think, like safeguarding, this is everybody's responsibility to create awareness of, and I think that needs to come through more within sort of society and our culture, hopefully.
Thank you. Maria, I saw you giving very positive non-verbal messages during that. Is there anything that you'd like to add?
I just think everything that Katie and Amanda have been saying just resonates throughout the whole thing. There's, when you talk, a huge taboo has always been sex. You know, people don't talk about sex, you can't talk about sex. And then you add in the older people element and it becomes more taboo. And that's why it's so important to be having these conversations today. And I think it's all around risk and needs assessment. It's all looking at the person, not what's happened to them, but the impact of what's happened to them. What's the person in front of me? What are their unmet risks and needs? What can I do for them? Yes, okay, it's important to acknowledge what's happened to them with regards to, is there a crime? Is there any safeguarding issues? But actually passing those on to appropriate services. And then Amanda mentioned before, IDVAs, using those specialist services to get these older people the right response for them. And we, it was back in 2017, just after Hannah Bowes' research, we were approached by the Home Office to provide training for ISVAs around supporting older people. And it had a great sort of impact. Lots of people attended because it was funded by the Home Office. Since then, people aren't attending the course because it's felt like, oh, it doesn't happen, but it does. When I worked at the Sexual Assault Centre as an ISVA, and my youngest client, or the youngest client at the centre, was 3 weeks old. The eldest client I supported, and she said, Marie, you're never going to tell me actual age. I said, don't worry. We always agreed with mid-80s. We took a couple of years off for her. Because it can happen to absolutely anybody. It doesn't discriminate. It's got nothing to do with the sexualised thing, like Amanda said, nothing to do with the alley, the dark alley, the short skirt, the drinking, the drugs. It is just, you know, there's no discrimination, and we really need to get this support right for older people because their needs are completely different to other sectors. So younger people that are impacted by sexual violence have different health needs, have different psychological needs, and the importance of getting this support right is vital. And I think I'm going to stop now because I know I've got a section later where I'll talk a hell of a lot more, but it was just Katie and Amanda were just everything that we talk about day to day. It's like, yes, yes. And it's so great to see hundreds of people on this call who are hopefully all doing exactly the same thing as well.
Thank you very much. One of the things that I'm going to put out a request for at this point, because I'm feeling that we've got something of a female bias here. We're all female panelists. Most of what we've been talking about is female victims, and I think we were also talking mostly about male perpetrators, but that is clearly not the limit of this topic. So I'm sure we've got in the attendees a huge wealth of experience of this topic, if we could pull it all together. And I would be very interested to hear from attendees who can give us insights into the other groups than the one that we've really focused on so far. I don't want this to come across as blind to people who are in double and triple jeopardy by reason of societal prejudices. So that's my plea for the next session. But if I could now move on and ask Poppy if she could do her presentation. Thank you, Poppy.
Thank you so much. And I just want to echo what everyone else has said so far with all the kind of contributions we've had so far. I've found them so interesting. And I can't help but agree with everything that everybody has said. So I'm going to talk a little bit about my work on the front line for Hourglass. Essentially, for those who don't know, I'm sure a lot of you do, we support those over 60 who might be dealing with situations of harm, abuse or neglect. And my role specifically, so I'm a caseworker that covers the Pan Sussex area. My role was funded by the Sussex Police and Crime Commissioner. because they felt there was an unmet need for older people suffering forms of domestic abuse and sexual violence in this area. I have had the pleasure of supporting a lot of victim survivors in my role, and actually a good deal of those have experienced some form of sexual abuse or sexual violence. I think a comment on the societal kind of preconceptions and that not meeting the kind of real rape side of things. I think, unfortunately, that's something that I've seen incredibly internalized by the victim survivors that I have worked with. They feel incredibly embarrassed, specifically with regard to their age, with regard to making disclosures. I've had some things said to me that really do stick with me with regard to that. Particularly, I think of a case frequently, which I think kind of falls along the lines of the research that Amanda has done as well. And I supported a 90-year-old who was sexually assaulted in hospital by a doctor. And she had suffered 2 mini strokes while she was in hospital to receive support. And actually, the first person that she disclosed to, their response was, "Why would someone want to do that to you?" Which I think is something that we had a lot of discussions around, particularly with this client, because I think that's such a damaging kind of myth to portray, particularly if that person has chosen you to be the first person to disclose something like that too. It can really inhibit that person making any disclosures going forward, feeling like they can report. If they do report, feeling like they could face the court system, where actually there may be more of that bias that comes into things. And I think with regard to commenting on the perpetrators of the cases that I've dealt with, there really is no common trend. I've supported on cases where the perpetrator has been a partner or an ex-partner, a case where it's been a neighbour, the doctor in a hospital, and also we do see inter-family sexual abuse with regard to adult children perpetrating this abuse on their older parents. I think thinking of this as a taboo subject, and I agree with well, I think it was Maria that said you kind of add the lens of an older person onto that, where there is this stereotype to keep things behind closed doors, particularly with regard to what happens within the family dynamic. And actually, there's a level of protection, particularly when it comes to adult children and not wanting to criminalise those adult children. And all of these barriers really do mount up to make it incredibly difficult for these people to disclose and then actually be able to engage with support. A lot of people that I've worked with, as I mentioned, that one comment, have experienced bias from professionals that actually has meant they haven't taken it forward with regard to reporting. They haven't felt they're going to be believed because they don't fall under what is seen as the perfect victim image, I suppose. And I think it's just really disheartening to me, particularly to hear the excuse of dementia used. And something that I worked with kind of people who suffer with dementia in care homes and nursing homes for quite some time before this role. People have fluctuating capacity. Just because somebody doesn't maintain capacity one moment doesn't mean they can't recollect what has happened to them, doesn't mean we shouldn't take those kind of claims seriously and investigate those. And the other thing that I've seen, which is incredibly distressing to me as a professional, is actually services going out to somebody that has experienced a sexual assault or a rape that is over 60, and they see somebody who presents as very distressed, somebody who maybe can't pin down a timeline of events immediately, can present as quite hysterical. And actually, their prejudgment to that is, this person looks over a certain age, they must have dementia. And this to me is, with regard to receiving referrals particularly, The amount of referrals that I have had to investigate with dementia diagnosis is that actually there is no diagnosis in that case. That person doesn't suffer from dementia. It's just the perception of people that have gone and kind of been disclosed to in that moment, and they see the confusion, the hysteria, and think that actually this person must not be in their right mind. I think we all, as professionals, have a duty to educate ourselves around trauma responses, around how each individual can react in completely different ways to trauma, specifically in this case, sexual abuse, sexual violence, and actually make sure that we're not holding any preconceptions around what we expect to see from somebody who has had that experience, because it will inhibit support being given and appropriate support being given going forward. So that's just something I wanted to touch on. I do think that we could make a difference, specifically with the dementia side of things, by actually training more professionals across the board in dementia awareness. I don't think it's something that should be specific to care homes, nursing kind of courses. Actually, I think it should be something that police have to undertake, that social workers have to undertake, that GPs have to undertake. And I'm talking more in-depth trainings rather than just kind of going through what might be presented by somebody, because actually that isn't going to, on a case-by-case basis, going to be effective for people. And they may then end up stereotyping across the board with regard to what they see as somebody who might suffer dementia. I'm going to stop there because I think my time otherwise will very much run out. I'm sure I can touch more on specific examples in the questions if they are relevant and come up.
Thank you very much, Poppy. And thank you to everybody who has kept the timing absolutely perfect, which makes chairing this kind of thing so much easier. Right, now we have not heard from Maria in a formal way, so I'm going to ask Maria, before we go into the big question and answer session, if there is anything that she would like to kick off with, and then we'll try and deal with what's come up in the chat room, what's come up in the question and answers. Maria, is there something that you would like to contribute at this point to kick us off?
Yeah, thank you, Mary. I just want to highlight a couple of things that we've found in our work within the sexual violence and safeguarding field with older people, and a few things that people aren't aware of or don't consider when supporting an older person with a disclosure, or supporting an older person who they feel may be impacted by sexual misconduct or sexual violence and haven't yet made that disclosure, and how to kind of support them. And I think a couple of things to be aware of is the fact that I'll hold my hand up, in my lifetime, I'm not making the presumption for everybody else, but definitely for older people, and in my lifetime, there's been many changes in the law. And it's the fact that, are people aware of these changes? So actually some of the older people we could be supporting or working with might not be aware that what has happened to them is illegal. So I don't always concentrate on the legality side of things. Obviously, I'm aware of the law and the Sexual Offences Act, and I can ream it all off if anybody wanted to hear it. But actually, what I focus on is what a definition is of sexual violence, sexual misconduct. And there's many, many different definitions. But what I love in the best definitions for me is the term unwanted. Unwanted, so something of a sexual nature that they didn't want to happen. That is enough for me to consider what support I need to give to somebody, or what services I needed for that person. Forget whether it's illegal, it's just something unwanted and it's had an impact on somebody. What is that impact? And I think we should focus on the impact, what we're seeing in front of us, rather than necessarily what has happened. Like I said before, appropriate services are needed, such as police potentially, but within our lifetime, marital rape was seen, you know, and very early 90s, 1991, which I feel wasn't that long ago, but I know it was, is that so rape within a marriage became illegal. Not that long ago, I phoned a GP for a client who felt they needed additional support from their GP, but they couldn't tell them what had happened to them. So with their consent, I phoned the GP to tell the initial information. So when my client went in, they could then say, I need help with this, rather than having to explain what happened to them. Luckily, I made that phone call because the first thing the GP said to me, do we call it rape when it's the husband? Yes, we do. There was a lot of professional challenge within that conversation, and safeguarding and updates and training suggested to said professional. But that's a professional, so sometimes it's not just service users, older people that we're supporting, it's challenging professionals around us with the language and some of the things that everybody's kind of brought to the table today, feeding on what Amanda, Kate and Poppy have all brought together. And even within that, things like male rape. Male rape was only recognised in 1994. So again, within our lifetime, and for older people, they might not want to come forwards because if they've engaged in sexual activity with someone of the same gender, they may feel that they're going to be prosecuted and seen as an offender, or, you know, prosecuted rather than being seen as a victim. So there's lots of things that can be barriers for people coming forward. And I think we have to take that into consideration. You know, it's we talked earlier about the gender. Sexual offences don't discriminate against age, they also don't discriminate against gender. Yes, a hell of a lot of statistics generally everywhere see females as the victim and males as the perpetrator, but that's not the case. We have non-binary victims, we have male victims, we have female perpetrators, we have children perpetrators. You know, there is no boundaries, and it doesn't sort of anybody can be a victim and anybody can be a perpetrator. But some of the laws don't help with this. So definition of rape, for example, you have to have a penis or a surgically reconstructed penis to be charged with rape. So, you know, some of the definitions within the law don't help with people coming forwards as well. And I think just touching on and bringing back to some of what Amanda was saying at the start, Hannah Bow's research that kind of came out in 2015, 2017, one of the things she said, and I had a conversation with her at the time around this because I was delivering a lot of training for older people, and I'm just going to read this because it's a great quote from her, is impacts are magnified for some older survivors because of the prevailing cultural norms in their earlier lives serve to inhibit disclosures and discussions of sexual violence. The things that we keep behind closed doors, we don't talk about sex, you know, it is that never mind sexual violence and things of a traumatic nature, you know, it's that stiff upper lip type of thing, and they have fewer opportunities to draw on for that disclosure, for that support, because they're not necessarily in employment, they don't have lots of social relationships, they could be isolated. And that's part of the issue with supporting some of the older people, is their opportunities to make disclosures and their opportunities to reach out for help and support. So I think when they do, it makes it so much more important to make sure that we are getting it right. We touched, Amanda touched on sexual assault referral centres before, SARCs. They can see people of any age. I used to support within forensic medical examinations, and I have been out to a care home. Yes, the preference would be in a nice clean forensic suite, but if someone can't be moved, doctors can go to them. And it can be, you know, having that balance. A forensic medical examination isn't always about the DNA and the forensics. It can be hugely therapeutic, and that can really matter to an older person with regards to having that time, having that attention, and having those assessments around their medical needs as well. So, you know, attending a SARC, not just from a forensic perspective, but from a therapeutic perspective, can be hugely important. And it can start their journey along the SARC pathway, then sort of having the appropriate support from an ISVA, having appropriate opportunities for counselling, and things like that as well. One thing that's often missed with older people, sexual health. Kate did say they are still sexually active. Yes, they are. So considering sexual health from a general perspective, but also considering it from that incident perspective as well. Yes, we might not be considering risks around pregnancy, depending on their age, but we're considering sexual health. They're still at risk of chlamydia, gonorrhea, hepatitis, HIV. We need to consider all these things, and not just, we think about sexual health with teenagers and young people, but not with older people. And it's things that are hugely missed. And I think, you know, that whole system and the SARC pathway with the forensics, or even if it's not a forensic sort of side of thing, just the support from the ISVA, they tailor their support needs to the client. And I think, you know, we're at the moment updating our training for ISVAs, because we do additional training around LGBT, we do additional training for children and young people. We want the older people now updated, because it's something that, you know, is hugely needed. And I think it's really important.
Absolutely agree on the need for training specifically for managing what is a very difficult issue for the staff, as we are discovering during this session. There is something that came on the chat from Sophia Mia, saying that trying to support an older parent from a non-English speaking community seems to be the theme, to engage with an IDVA, but was stuck due to language barrier, and parent having to use child as the interpreter. Now, my training in the NHS is that it is never acceptable to use a member of the family, regardless of age. I don't know when, if Sophia is talking about child, meaning an adult child or a young person, but it's never acceptable to use the member of the family as the interpreter for all these reasons. But that is sometimes you're always advised to get an interpreter. Using the telephone systems can be clunky. Using the phone-based translators can be very clunky. It's often disputed by bilingual staff who feel that they have a way into that patient's trust by being bilingual. But I just wonder what the experience of people, non-NHS practitioners, is about getting interpreters. Is this going to be a further barrier, another jeopardy for those people whose first language is not English? Can anybody help me on that one?
All ISVA, from an ISVA perspective, all ISVA services have access and are told to use interpreters. One, because of the impact for family, and two, if it's not interpreted in the correct way. But I always say as well, if you're using an interpreter, have a chat with the interpreter before you start the conversation with regards to what you're talking about, because you don't want the interpreter to be impacted, because they could have been a victim themselves and it could be hugely traumatic. So I come from an NHS background. So when I was a nurse, it was second nature. We'd just talk about broken arms, stitches. But actually from a sexual violence perspective, I think it's just common courtesy, but it's also being human, and just thinking, actually, we're bringing someone into a sexual violence misconduct conversation, and actually, are they prepared for that? Just because they're paid to be an interpreter doesn't mean that they can't be impacted by the conversations, and just making sure that that discussion takes place before you join the conversation with a client, I think, is something for everyone to remember.
That's a really good tip. I'd like to cover a question that came in on the chat from Kelly, and I think Amanda may be the person to help with this, because Amanda, you made the point about this is much less about sexual orientation and sexual gratification. This is much more about power and control. Kelly's question was about the shift, is there a shift from being interested in child abuse to being a practitioner of abuse of older people? My information about this is really quite out of date, and so I'm going to ask Amanda to help. I know that many years ago, probably 30 years ago, there was a publication from Sheffield about the impact on applications for jobs in the childcare sector when the DBS of the day came in, and those who had bad child records shifted to applying for care home and domiciliary services for elderly people, suggesting that this was about power, control, coercion. Amanda, do you have any update on this for us?
I think in terms of research, again, that it's something else that there's a gap in. But we do know that perpetrators of abuse, whether it's domestic abuse, sexual abuse, child abuse, well, that power and control is often easier to exert over somebody that's vulnerable. And that vulnerable person could be a child, it could be a person with disabilities, it could be an older person. So I think, yeah, I think for a lot of people, it isn't, as I said, about that sexual interest, whether it's in children or older people or people with disabilities. It's about somebody that has a vulnerable situation that they can exert power and control over.
Sorry, I forgot to unmute myself. Yeah, thank you very much. That's really helpful. And I think that might bring us into a question from Celine. I'll just read this out so that we've got the context. I'm wondering about the awareness of females who are sexually offending. It's really difficult to get prosecutions for men sexually abusing older people, but the reaction to concerns that a woman is sexually abusing older people is often dismissed or ignored. She was providing intimate care to the woman, or if it's a man with a sexual service, wasn't he lucky? And more and more of these abuses being recorded, and the concerns of older people that these are being shared. I'd like to put into the start of the response to that by talking a little bit about because there was also interest in the earlier Q&A bits about gateway offences and the idea that there is a verbal run-up to some of these physical abuses. I'm aware of the belittling comment about both older men and older women made by carers, which have been made in my presence. The comments about the aged breast, about the lack of sexual potency of older men, these belittling remarks, to be crude, but he can't get it up anymore, or saggy old tits. These are all comments that have been made in my presence, and if those are made in my presence, what barriers have been breached when I'm not around? And I just wonder if anybody else has would like to add to that.
I've found that previous to my work now for Hourglass, I worked in a multitude of care and nursing homes, and experienced similar from other colleagues, not just even kind of on the care side of things, but nursing colleagues. And it's quite distressing that often this can be pushed off as some sort of like workplace banter. It should be taken seriously, and actually what I find quite upsetting is that often these things, even when they are reported, because I've made multiple reports myself whilst working in those places, it doesn't always get acted on in a way that is going to prevent that going forward. I think it was a really interesting point that somebody made about that sort of the acceptable kind of, I suppose it was the term gateway kind of behaviour was used. And I think putting a stop to it at that level is incredibly important, as the point was made, to stop it from kind of becoming any more of an issue and those issues escalating and behaviours escalating. But unfortunately, it's something that I've come across in my line of work prior to this as well.
Anybody else from the panel got anything that they want to add to how we deal with that situation?
I don't have anything to sort of add
Maria,
to that. Sorry. Oh, sorry, I'm not sure what happened there. I think my Wi-Fi went funny. Not to add to the situation, but I also think within this, there is this sort of level of acceptability and the way that this kind of conversation is had online within adult sites. Older people content is a genre. And I think that's another thing, sort of a layer of it, that it's becoming this acceptable type of genre of pornography or adult content that is available. And that is just kind of adding to the acceptability of this terminology as well, that, as you say, saggy old tits is a search term that you could use on an adult site. So of course that this is going to kind of feed into like how people talk about it, depending on the type of photography that they're consuming. So just kind of add, that's completely going off a tangent, and I could probably talk about that side of it all day, and I know we're near the end of the webinar, but just wanted to add that in.
Thank you. Sorry, I'm constantly muting and unmuting, and it's possibly not helpful. A question that perhaps Amanda might want to deal with. I think you helped with this in the chat, Amanda. Questions about the questioner wanted to address issues about specialist approaches to LGBTQ people. I think you suggested making safeguarding personal would be the first line to follow there. Do you want to expand on that?
I don't think it was me in the chat, actually. I think there's another Amanda, although I do know that my colleague from Cambridgeshire County Council, Christine, is on here, and she's also mentioned in the chat about making safeguarding personal and not looking, it's not about looking for filling out tick boxes. It really is about focusing on the particular needs and circumstances of that individual.
Right. Sorry, if any of the other panelists can correct me about who did reply, but maybe it was one of the other attendees that did that. That would also lead us into the idea of back into the idea of training. This has been raised in multiple contributions in the chat room. Perhaps we could just have a minute or two to summarize what training is available to our knowledge, because clearly people are interested in, they've come on this webinar today, but what else do we recommend as training from our own organisations? Maria, do you want to start that one?
I was going to say, this sounds like a bit of a plug now, but we at Limeculture, we do have older people's training, which it's an elective for ISVAs. So someone has to have had and completed their ISVA training or be a qualified ISVA, and they can have that as an additional add-on, because it's just the specifics of working with older people. However, my colleague who's also on the chat, Peach, has put out a message. If there was interest from other services, we could do a generic sexual violence and older people's course that isn't just ISVA related, because it is around, we are sort of sexual violence experts. We are working with Carrie, who's also here from Age UK, to get that sort of side of things in. And I think it's great that we've got these people here, but there's not a lot of training out there. And I think, you know, if anybody is aware of anything, please feel free to share it. But from our perspective, we struggle to find. So we've created our own at Limeculture, and we can potentially adapt it if there's enough interest. So please reach out to myself after or through Hourglass, who can pass on our details as well. But I don't know if anybody else is aware of sort of any service sort of open training or specific training.
I would just say, when I have spoken to NHS staff in training, one of the difficult issues that comes up is the interpretation of bruising. And actually, this is one of the areas where there is more solid research than other manifestations of physical violence. There was a systematic study of bruising done at the Mosqueda, it's Orange County in the US, at the behest of the criminal justice system in the US, because they were constantly getting cases that went to court and fell because nobody could say what the true interpretation of the bruising was. The idea that it's an aging, it's the drugs, it's because she fell, those kind of getting off the hook defenses succeeded. So research on what bruising in older people actually looks like, in terms of where it is, what color the bruises are, what drugs are associated with it. That was systematically studied over a 6-week period in volunteers who were examined. They were stripped off every day and examined. And so there is good evidence about what normal elderly skin looks like. This is in white people. You know, but you have got to start somewhere. And what should be taken more seriously. It's fine to have a few things on the back of your hands. That isn't of great importance. But it's very important to take a drug history to know whether larger and more extensive bruising does have another explanation. So I think that there is an awful lot of training that we can bring in, and somebody in the Q&A put in the comment that's very, very important to have intersectional approaches to this. And this is my plea. Let's get everybody working together about it. Now, I'm beginning to see that we're getting up to our time. So I'm going to thank everybody again in the back room, on screen, everybody who's contributed. And I'm going to ask everybody from the panelists to just put one little sentence. You've got one sentence as a takeaway message. And Maria, you're on my screen at the moment, so why don't you start?
So my take-home message is that the type of incident doesn't equate the impact. Look at the person in front of you, and what are their needs. Whether it happened 10 minutes ago or 10 years ago, it's current for that person. So just look at the person. Don't forget the basics of what you do.
Thank you. Right, Amanda, would you like to go next?
Yeah, I think my message is just stop making excuses. The excuses that we've heard today about people having dementia, people being distressed, and sort of unreliable witnesses and things like that. It doesn't matter. If a crime has been alleged to have taken place, that person needs support.
Super, thank you. Poppy, do you want to give a take-home message as well?
Yeah, I would say remain judgment-free, particularly with regard to disclosures. Get all preconceptions out of your mind and be person-centered, and see the person in front of you and how you can support them specifically going forward, as well as having that intersectional lens in mind.
Thank you. And last but not least, Kate, what's your take-home message?
Mine would be that everyone can be affected, but everyone deserves to be supported. So be kind and do what you can to support people individually.
Thank you. And can I reiterate what I said at the beginning? Be kind to yourselves as well. Support each other. This is difficult work. And we really, really do need to look after ourselves in order to be able to look after the people that we are focused on today, older people who have been the victims of sexual abuse. Unwanted is the big word that that I'm taking out of this. No victim blaming, no excuses. If it's unwanted, it's unwanted. I will repeat a couple of things that I said at the beginning. I think they may have already put this in the chat room. This is being recorded. You can get the recording shortly, and everybody's welcome to bring colleagues to listen to that. I'm also going to do an unashamed plug for our conference, which is on the 19th of March in Brighton. It is the 30th anniversary of Hourglass in its various iterations. It's got an absolutely stellar list of speakers, and those speakers represent so much the themes that we've been talking about today, the intersectional lens that has been the emphasis today will absolutely be there. So please go on the website, read all the other stuff as well, but see if you can possibly come to the conference. Well, I think we might be a minute or two over, for which I crave your indulgence, but thank you everybody for coming along. This has been just such an amazing experience for me, and I hope it's also been transformational for you. Thank you and goodbye.